Ladies and gentlemen, dear colleagues, first of all, I would like to thank organizers and personally Mladen Janovic for opportunity to give this speech about laparoscopic surgery of cancer. It is very great honor for me to be there in Serbian, and sorry for my English, I've been learning it for some years but can't speak well. Minimally invasive surgery for treating upper GI malignancies is more controversial than laparoscopic colorectal surgery. After first laparoscopic subtotal gastrectomy was performed by Sergio Kitana, providing technical possibility of these procedures. A lot of studies were conducted, but we still don't have the definitive answer if laparoscopic approach is beneficial compared to open procedure. One of the first randomized trials was Class 01 trial. Its interim report regarding short-term outcomes was very reassuring and inspired surgeons all over the world to introduce this technique in their practice. Last year, there are several reviews published. One of them was dedicated the LAPAC approach in early gastric cancer was concluded based on meta-analysis more than 2,000 cases that evidence is sufficient to justify LAPAC approach in early gastric cancer. Nevertheless, there are some ongoing trials aimed to investigate not only technical feasibility and oncological safety, but long-term results as well. We are waiting Class 001 long-term results this year. Japanese Society of Gastric Cancer 0912 trial results will be published in 5 years, and Class 03 has just finished enrollment of patients last year, and we're waiting for their results as well. Talking about local advanced gastric cancer, we can turn to recently published reviews saying that LAP approach is safe only in selected patients. There are also some trials that presumably will give us the answer. Class 02 is about to begin. Japanese Laparoscopic Society group is already recruiting patients, and Japanese Class 01 study is supposed to be published in 2017. So, to sum up, there are always a clash and struggle between laparoscopic and open. And evidence is the only thing that we can give us the answer. These guys on these pictures will find who is right and who is wrong very soon. I think you would all agree that rather than conducting trials for many years, we would appreciate to have a sumo boxing round or hockey or football game to find out which approach the best one. But unfortunately, football is one use here and has no relation to gastric cancer surgery. Or has it? This picture looks very familiar, but if we add some details and bit of imagination, we can clearly see that these are colectric and his branches. Left gastric artery, common hepatic artery, and splenic artery. And players are lymph node groups. And we add some tactics, we can see the steps of lap gastrectomy. So let's go through the lap gastrectomy through a football game. Any success attack starts with a good opening. So, we open the lesser sac by transection the avascular layer between large omentum and transverse column. There are no any evidence-based data about necessary to remove omentum in all cases of gastric cancer, but Russian surgical schools require the omentectomy. Japanese school says that we need remove only 3 centimeters from gastric epiploic artery. But in our country we have to remove great omentum in all cases, but in open surgery this step is not very difficult, but in laparoscopic surgery, especially if patient big man like I am, it is very, very, very difficult. The next step, we go into the 6th lymph node group. The main danger of this stage is hidden of gastrocolic trunk of Henle. Injuring this structure results in venous bleeding very hard to deal with. We dissect left gastroepiploic vein and artery. In this group, we remove 14 lymph node, it is not necessary regarding to last Japanese guideline, but you will see the enlarged lymph node and we decide to remove it. This step may be very safely if you will have a good cameraman and you will go to the layers. We transect right gastroepiploic vein very close to gastrocolic trunk. After that, we try to identify gastroduodenal artery and its branches, and try to transect right gastroepiploic artery on right vision control, because upper gastroduodenal artery localized very close to this area, and in case of injury of this artery, we can find the postoperative complications. This step, the last step during the lymph node 6 removing. How this is done? We form a kind of tunnel behind the duodenum, just wide enough to put the stapling device in and transect the duodenum. In case of open surgery, we perform this step after transection the right gastric artery. But in case of laparoscopic surgery, this step is very important thing, because after that we continue to dissection with defining the anatomy of gastroduodenal artery, proper hepatic artery, to have a better understanding the landmarks. These landmarks we need to go for 12A lymphatic groups around proper hepatic artery. We continue our attack to proximal direction number 5 lymph node, dividing right gastroepiploic artery, and dissection 5th group of lymph nodes. Now this step very similar, only dividing of right gastric artery. After that we continue along the hepatic and transect less amentum. And in step of removing of lymph node group number 1, we use the cruise of diaphragm like landmark. Then we come back at direct common artery, removing 8A group of lymph nodes. Anatomy of this zone is very clear on the screen. That is a certain advantage of laparoscopy. We try to use a hook on this step because it's much more useful than bipolar instruments. And one trick, we try to elevate common hepatic artery up down and try to identify portal vein. After that, we proceed to celiac trunk, where the ninth group of lymph nodes is located. We dissect the anatomical area, visualization, trifurcation of trunk. On this stage, we clip left gastric vein as well. And this is the overview we like to have after this part of the surgery is done. We like to see portal vein and bile duct. This not step of surgery, I tried to show the surgical field. Then we go for the left gastric artery, thus dissection 7th group of lymph nodes. This very simple step of surgery. We go on with dissection along the splenic artery, dissection 11P lymph nodes. Moving along the crus and diaphragm and adrenal glands, on the left we create a cell helping us. We are going along the artery until it identifies posterior gastric artery. We can look it for on this video. Next step, the moving laterally, we clip and cut left gastroepiploic vessels, dissection group number 4. After that, we start to dissect 11D group and 10th group lymph nodes. It is very difficult step of surgery because in this case it looks like easy. But in case of some veins and some arteries, especially very close to the spleen, it is very difficult part of surgery. In difficult case, we use the taping of artery and vein. You will look it for later, these steps. And, this trick allows to remove all lymph nodes, especially lymph nodes 10th group. I tried to make this clip shorter, but it is impossible because this step is very difficult technically, and I tried to show only some minutes of this surgery. That is overview what we have done, and in our view it is repeating this step-by-step approach in every surgery, what makes a good quality of surgery. This is a transection of esophagus, anastomotic creation. Maybe I can show this step after our session because it needs the time. But what about our results? Nowadays, overall 87 gastric cancer underwent laparoscopic gastrectomy or partial gastrectomy. 14 patients were converted, conversion rate 16%, which give us 73 complete laparoscopic procedures, among them 26 total and 47 subtotal laparoscopic gastrectomies. Conversions were mostly related to bleeding, complicated anastomosis formation, especially esophageal anastomosis. Less were due to bleeding, and in 2 cases, underestimation of 2 T criteria occur preoperatively, and we had to go open patient and perform Whipple procedure. From December 2009, we are prospectively gathering data of patients with T1B or T3 adenocarcinomas. On average, we remove 26 lymph nodes. Blood loss is about 100 milliliters, and the duration of surgery around 4 hours. There were some complications during the surgery and in post-op period. Presence of stapled line is causing some problems with the bleeding. Expectedly, there were some bleedings on the table and some leaks post-op. There was one death in the group. Complication rate in lab group is almost the same with open surgery. In conclusion, the surgical derby between lab and open is ongoing. Current evidence based in our own data make us believe that in selected group of patients, laparoscopic gastric surgery performed by selected group of surgeons are beneficial to open. Nevertheless, I can tell you anything now, but in the end of the day, it is surgeon who decided that operation is preferred. And making this decision in every patient, we should use our